Hello, everybody. My name is Kara Motonaga, and you also see Eric Silver on this video. We are the co-chairs of the Pediatric and Congenital Electrophysiology Society Education Committee. And on behalf of PACES and the Sudden Arrhythmic Death Syndromes Foundation, we would like to welcome you to our conference today entitled Pediatric CPVT, Let's RYR2gether. We have an exciting conference planned today with our distinguished speakers, and we hope you'll all enjoy it. We were very excited to partner with SADS for this educational conference, and we are very excited to have 256 registered attendees as of this morning. About 60% of those registered attendees are physicians, 10% are trainees, almost 30% are allied health professionals, including genetic counselors, advanced practice providers, and research development or industry individuals. We have 38 countries represented by attendees from 6 continents across the world. So we are super excited to be able to share this conference with everybody, and we look forward to everybody's questions that may come up. First, we would like to thank the PACES Education Committee as well as the Executive Committee for their support and help in organizing this conference. And we would especially like to thank the SADS staff and leaders, including Aaron Waite, Alice Lara, and Marcia Baker, who have been phenomenal in helping us organize this and put this together. So we're going to all run very tight on time for this conference, so we're going to try and keep things moving. So with that, I'm going to hand it off to Eric, who will introduce our first speaker. Oh, you're on mute, Eric.
Thank you, Kara. All right, thanks, Kara. So I'll be introducing presenters joining us from interesting places around the world. To get us started, it's my pleasure to introduce Professor Silvia Priori. Dr. Priori is joining us from Italy. Italy, known for its incredible food, art, and storied history. Her talk is entitled, A Look to the Future, Precision Medicine and CPVT. Thank you, Dr. Priori.
Thank you very much. Let me see if I can share my screen. Okay. One more step. And here we go. Thank you very much for the introduction. It's a great pleasure to be here with you virtually, but still with enthusiasm to talk about a look to the future, precision medicine in CPVT. So as you know, the term CPVT is an acronym for the name of a disease called Catecholaminergic Polymorphic Ventricular Tachycardia. And now we say that CPVT is not just one single disease, but is a group of diseases that share certain features, certain manifestations. They are in fact characterized by adrenergic-induced, bidirectional, and polymorphic ventricular tachycardia that interestingly occur, as in the other channelopathies, in a structurally normal heart. So there is a new classification that has been recently proposed that based on the type of gene that causes one of the form of this CPVT disease, we can divide them in typical and less typical. So the most common and typical are caused by mutation in the ryanodine receptor and in the cardiac calsequestrin gene. That is, calsequestrin is a regulator of the ryanodine receptor. Then we have these rare forms that are triadine, calmodulin, tecarl, and other type of mutations in the ryanodine receptor. And these one are the less typical because their clinical manifestation are not identical to that of the previous group, the typical CPVT. This group is the one that is most known to be associated with arrhythmias that are exercise-induced or emotion-induced. And they are treated for that reason with beta blockers. And another important addition on the treatment of these conditions is flecainide. When we move to the other non-typical forms, then First of all, these are rare as compared to the other one that are the most prevalent, the most common, but they are less often associated with exercise-induced arrhythmia. And they also have the manifestation of another channelopathy, and they have a prolonged QT interval as well. They do not respond so well to beta blockers. Some patients do, some others don't. And the outcome is less favorable than the one of the typical CPVT. Having said that, this is just to show you why the bidirectional VT is the typical one of the typical form of CPVT, and this is what we mean by bidirectional, that the axis of this beat is negative, this one is positive, negative, positive, until, unfortunately, there is a very rapid arrhythmia and the patient has a cardiac arrest. This is diagnostic for the typical form of CPVT. So here are other characteristics that I have described that are summarized in a snapshot of what is the typical form and what are the non-typical forms. And here the questions about the therapy, the differences, beta blocker and flecainide, not so sure that beta blocker and flecainide will protect all the patients. So staying on the topic of therapy, that is the main subject that I will cover, considering that the genes may respond or not respond to the classical therapy, I think that this points to the fact that maybe we should try to develop therapies that are specific for the different forms of CPVT. And this is what we mean when we say that maybe for CPVT, it's time to start thinking of a gene-specific therapy, a therapy that is specific based on the mutation that the patient has, and in particular, the gene in which the mutation is located. So we started designing therapies that are not molecules, that are not chemical drugs, but that are molecular therapies, DNA or RNA used to treat the disease. And now that we are in the time of COVID and we have seen how important the vaccine has been, we have also learned that the vaccine is made of RNA in most of its formulations. And therefore, everyone has become a bit more familiar in this concept of molecular therapies that treat people with DNA or RNA molecules. So to treat the recessive form of the typical CPVT, where we have a problem in this protein called calsequestrin, we have to make some reasoning and say, so when there is a mutation in calsequestrin, what happens to this protein? So what happens to this protein is that it is reduced because the mutation leads to the degradation of this protein. So since calsequestrin is able to regulate this protein called ryanodine receptor, the very famous RYR2, if calsequestrin is not present, the RYR2 start losing calcium at times in which the calcium should remain inside this area of the cell that is called sarcoplasmic reticulum. So if we lose calsequestrin, the calcium goes out and triggers the arrhythmias. So what we wanted to do was saying, okay, if all the problem is related to the fact that with this mutation, with the changes of one amino acid, calsequestrin is dramatically reduced and cannot control the ryanodine receptor anymore, maybe the right therapy in this setting would be to try to increase the amount of calsequestrin. And this might be done with a gene therapy. So if the calsequestrin is missing, what we do? We take the DNA of the human calsequestrin, we put it in a structure that is called the plasmid, and we put the plasmid that contains in orange the gene of calsequestrin, a perfectly normally sequenced gene, and we place this construct, that is the plasmid plus the calsequestrin, inside a virus that is a very special one because it's been adapted to contain a nucleic acid, is not able to replicate and kill the cell as it happens in an infection, and this virus can be injected into the heart. And here we see that with the same slide as before, the mutation reduces calsequestrin, and here calsequestrin goes back to normal. And when calsequestrin goes back to normal, all the other proteins that were reduced go back to normal value. So here we see calsequestrin reduced with the mutation goes back to normal at the line of 1, that is the line of normal level. The calsequestrin goes up, the junctin goes up, the triadin goes up. So all these proteins that are linked to each other return to normal. And this, of course, we want it to be related to a therapeutic effect. So here we see our bidirectional arrhythmia in the mouse that has CPVT when we give catecholamine to this mouse. But then if the mouse is treated and there is an infection, INF, that brings back the normal level of calsequestrin upon stimulation with epinephrine, we have no arrhythmias. And here we see that 6 months after gene therapy, still very important reduction of arrhythmias, 12 months, no arrhythmias at all. So this gene therapy can be promising. And I think that it's interesting to know that a clinical trial to be performed for this therapy had been approved by the FDA. So we might not be very far from the concept that this, with the help of a pharma company interested in developing this therapy, that could be tested in patients affected by this disease. We have also a therapy for the dominant CPVT, and I want to explain to you the concept and why it is different than the therapy for the recessive form of the disease. Here we have mutations in the ryanodine receptor itself, here. And if this is mutated, what happens is that the calcium goes out at the wrong time, as we have seen when we have a defect in the calsequestrin. So the story is the same, that there is always the development of an extrasystolic beat and many other beats that leads to a ventricular tachycardia, because the calcium exits the sarcoplasmic reticulum at the wrong time. But here, instead of working by increasing the calsequestrin, since here is already normal, the calsequestrin, we want to remove the protein that is abnormal. And how do you remove a protein that is abnormal? You use a mechanism that is part of the cell biology that is called RNA interference. So we design a molecule of RNA that is very small, but very precise to go where the RNA of the wrong ryanodine receptor is located and inhibits the production of the abnormal protein. So what we see happening here is that when we deliver these very special molecules that can bind only to the mutant ryanodine receptor RNA, we are able to suppress it. And what we see here, instead of having the arrhythmias that develop when we have both the normal and the abnormal RYR2 RNA, here what we have, it's only the normal RNA is present because the other one has been depressed and removed by these RNA molecules that we have introduced. And here you see that there are no arrhythmias anymore. And once more, here we see that over time, the arrhythmias are very much reduced and even suppressed when we have infected our animals with this therapy. And on this line of targeting therapies to the specific defect of the disease, other examples have come up in the area of CPVT. This is an example from Bezerides, published in Circulation, where he exploited an idea that if we inhibit a protein, actually kinase and enzymes, that is called CAM kinase inhibitor because inhibits this enzyme, the result would be to abolish the arrhythmias. And so they prepare the gene therapy structured in the same way as ours, but with the objective of inhibiting this CAM kinase. And as you see here, the arrhythmias present before, after the therapy disappear. So I think that I would like to conclude by saying that we need to move this gene therapy to the clinic. We have still some steps to achieve, like be sure that the patients don't have antibodies that can kill the vector, the virus that brings the gene therapy. We want to have much more precise targeting therapy that will go only to the heart. We want to reach a high rate of infection and uniform distribution into the ventricles. So we are working to achieve these targets, and we would like the patients and the colleagues to be aware that the same approach that has been successful for COVID-19 might in the future be successful to mitigate the manifestations of CPVT. Thank you very much for your attention.
Thank you very much, Dr. Priori, for that wonderful presentation. I just wanted to let our audience know that in the WOVA app that you're viewing the session in, there is a Q&A section that you can feel free to submit any questions for our speakers. So feel free to submit a question to Dr. Priori if you have any about her discussion. Dr. Priori, we're waiting to see if any questions come up from the audience. I was just wondering your thoughts on what do you think is the biggest roadblock to actually making this kind of theory become a reality, to actually get it to be done in humans?
Yeah, I think that, there are thousands of studies in gene therapy nowadays. Unfortunately, very few have been performed in the heart because we have had a difficult start from the first study that was actually not a study targeted to gene therapy for an inherited disease, but was attempting to cure heart failure. And this therapy, despite the good efforts that the team who had developed that therapy placed, was not successful, probably because the strategy was not ideal to prevent heart failure. But it made an important point clear that the heart can be infected, and then the patients did not have important side effects. So none of them had a worsening of the heart failure. So I think that this set a stage where we have some premises that is something that developed with the appropriate adeno-associated viruses is safe. The more difficult point is to decide the dosage that should be given. Of course, these molecules are different than the molecules that you take as pills because they do not go away. They are in your body and they continue to be produced. So you need to identify a dose in a careful way that it doesn't reach an excess of these proteins that are either turned off or turned up. So I think that one problem is to define the dose. The second problem is that the patients may have already antibodies to these native adenoviruses because they are present in nature. So there is another line of research in laboratories specialized in manipulating these viruses that are making viruses, new viruses that for which the patients will not have the antibodies. So I think that on one side, the dosage, on the other side, the prevention of the antibodies are the challenges that hold back so far the application in the clinics. You're mute.
I was muted. Yes, thank you. Thank you so much for that answer. And this is a very exciting field that we hope will, be something that we can offer to our patients maybe in our lifetimes. We'll see. I don't see any other questions coming from the audience. So I think in the interest of time, we'll just move on to our next speaker. Thank you so much, Dr. Priori, for your presentation. Our next speaker is Dr. Prince Cannon-Carroll. He's a professor of pediatric cardiology with faculty appointments in both the Vanderbilt Genetics Institute and the Vanderbilt Center for Arrhythmia Research and Therapeutics, and serves as co-director of the Center for Pediatric Precision Medicine at Vanderbilt. He is going to give us a talk on first-line medical management in CPVT, beta blocker, flecainide, or both. Thank you so much, Dr. Cannon-Carroll.
All right, thank you. Kara, just make sure, let me know that you can hear me and see my slide.
Yes, we can.
Perfect. All right. So Thanks to Kara and Eric and Aaron and SADS for putting on this this great session. It's an honor to follow Dr. Priori, who gave us a nice look at the future of therapy for CPVT. I'm going to be talking more about the present, first-line medical management in CPVT, beta blocker, flecainide, or both is the title of my talk. And if you need to leave, the answer is all of the above. Obviously, it sort of depends on the situation. So let me see if I can advance my slide here. All right, there we go. So I'll be going over medical management in some of the common presentations of CPVT. I won't be talking about activity restriction, even though that is, of course, a very important discussion to have when we make the diagnosis, because Peter Aziz is going to be talking about that in a little bit. I'm also not going to talk very much about the role of left or right or bilateral cardiac sympathetic denervation, since Thomas Paul will be covering that next. And I'm also not going to talk very much about the role of the ICD. We have a very exciting debate at the end of today's session that's going to go over that question. And so what I will talk about is medical management in various clinical scenarios. And I'm mostly going to be talking about patients with an unambiguous clinical diagnosis of CPVT. That is, those who have polymorphic pairs or non-sustained VT or VT on their exercise treadmill test. And we'll talk about various presentations, starting with the most severe, those who present with a cardiac arrest, and then move on to those who present after syncope or some other cardiac symptom like a seizure. And then we'll move on to those who were not presenting with symptoms, but who were diagnosed from family cascade testing, and also touch upon the family member who has a variant in RYR2 that's pathogenic or likely pathogenic, but has a normal treadmill test. So we'll start with that first scenario, those who are diagnosed with CPVT after a cardiac arrest. And I'm going to use this paper that was published a couple of years ago as sort of a reflection of what's going on in the literature. Most of you are familiar with this paper. Of course, it was really answering the question of what is the role for the ICD in patients who present with cardiac arrest and are then diagnosed with CPVT. And I'm not using it for that reason, but this is the largest series of patients published who presented with a cardiac arrest. So it's fairly useful for our purposes here. And so if you look at the entire cohort and we look at the medical therapy that they're on, we'll see that almost everyone is treated with a beta blocker, with nadolol being the single most common beta blocker used. We see flecainide use and LCSD use in what I would say are fairly low percentages for patients who present with an arrest, 28% and 7%. Now, of course, in this paper, slightly more than half of these patients also received an ICD. But if we focus on those who were not treated with an ICD, we see, again, beta blocker use in almost everyone, with nadolol use being a little bit higher in that cohort. But still, what I would consider relatively low use of flecainide or LCSD. Now, again, this is a retrospective registry, so we don't really know all the details, and certainly patients may have had additional therapies used shortly after diagnosis. But I would say my personal practice for patients who present with an arrest is to use nadolol at a fairly high dose, plus something else. Most of the time, that's going to be flecainide, occasionally LCSD. We also have to wonder, why are there some patients that are not treated with a beta blocker? Now, some of them may be truly intolerant. I have heard about practitioners who are hesitant to start beta blockers because of sinus bradycardia, which is, of course, part of the CPVT phenotype as well. And I would mostly want to make the point that that's really not too big a concern in most pediatric patients. Many of them can tolerate very low heart rates without significant symptoms. And I'll show you a fairly dramatic example of that here. This is an ECG from a girl who was 8 years old at the time. She did not present with an arrest, but she presented with syncope. We had her on propranolol. She came back with syncope, and so we brought her in and put her on a total of 10 mg per kilo per day of propranolol, plus 10 mg per kilo per day of verapamil. So this was long before we knew anything about flecainide, and before we knew that nadolol was definitely better. And you can see her sinus rate is in the 30s here. She's got a fairly prolonged PR interval. and her sinus rate is slow enough that she actually has these escape beats. But she's completely asymptomatic with this. This is her resting heart rate. When she gets up and walks around, her sinus rate increases, her AV nodal conduction improves. She never had any AV block. Now, obviously, this girl has grown up and is now on Nadolol and flecainide, and her ECG does not look like this. But again, this sort of just drives home the point that bradycardia is rarely a reason to avoid aggressive medical management in young CPVT patients. All right, now we're going to move to the next category. Those are patients who are diagnosed after syncope. And we can look to the PACES multi-center registry, which is still the largest series of CPVT patients in literature. And we see that this is the most common presentation. Syncope is the most common single symptom that patients present with. And so we can look at the treatment in the registry. Again, this is not only patients who present with syncope, but it reflects most patients. And again, we see beta blockers are used in almost everyone, with a bit higher use of Nadolol, which again is the preferred beta blocker in CPVT. Flecainide was used in 24% overall. Now, this was back in 2015, so that number is probably higher in practice today. But most of the time, this is used as subsequent therapy. And I would say this reflects my personal practice as well. For patients who present without an arrest, I'll initially start them on Nadolol. And I won't start flecainide right away unless something happens. That something could be further symptoms, or more likely a treadmill test that we don't like. And we use the treadmill test because of this data that came from Maiso Hayashi's group, with Antoine Leonhardt being the senior author here. This was at the time the largest series back in 2009. And they really showed us that if we see that couplets or non-sustained VT is seen on the most recent exercise test in 2/3 of patients that have subsequent events, compared to 1/3 without events. So this is a fairly sensitive and specific marker of subsequent events in CPVT. So most of us will start medical therapy, get steady state, and then perform a treadmill test. And we really want to drive the ectopy down to less than couplets or non-sustained VT. So what about family cascade testing? Once we diagnose one patient, we want to make sure we test all of their first-degree relatives. And the quickest way to do that is still with an exercise test first. And so this paper from Miyuki Hayashi, as the first author, still from Leonhardt's group, show that in exercising 67 family members, in this particular cohort, 17 had a positive treadmill test. And of course, most of them had positive genetics. And for the most part, they're treated like CPVT patients with beta blockers. Those who aren't treated have a fairly high event rate. But we see patients who have a negative stress test who still have positive genetics. And so these phenotype negative, genotype positive patients actually have a not insignificant event rate in follow-up. And so if they're treated, they do fairly well, but those who are not treated still have events. So it is recommended that phenotype negative, genotype positive patients are treated with beta blockers. So if we go through the family here and say, what does your initial treadmill test look like? If they have couplets or non-sustained VT on their first treadmill, we treat them fairly similar to symptomatic patients. There's a little bit of caveat there. If we look at the data on the exercise test, we see the negative predictive value is fairly high, but the positive predictive value is only 0.45. So if we're very aggressive about eliminating every couplet in an asymptomatic family member, we're probably over-treating. So if I've got particularly an older family member who's never had a symptom, who had non-sustained VT on their first treadmill and on Nadolol, they just have couplets, I probably will let them go with just that. Of course, continuing to follow them for symptoms and also with repeat treadmills. If the initial treadmill test has just single PVCs or bigeminy, then that's a treadmill that if that were on therapy, we consider that already adequate. And so for those folks, I pretty much use Nadolol alone, again, reassessing over time for either symptoms or for a treadmill test that gets worse. And then what about those that have no ectopy at all, the truly phenotype negative, genotype positive patients? Again, it is recommended that they're treated. I typically discuss the benefits and risks of Nadolol and typically recommend, a fairly, what I consider a low dose, 1 mg per kilo per day of Nadolol with a repeat exercise treadmill test on about a yearly basis. Again, not every family member actually takes Nadolol, and I don't fight them too hard if they've had no symptoms and have a completely clean treadmill, but my preference is that they do get treated. And all this sort of begs the question, what sort of exercise treadmill test do we do? Well, you know, forever I've been doing a standard Bruce protocol, but I recently started to change that. And that's because of this, this recent paper from the Vancouver group. They found that, you know, a handful of their healthy CPVT family members who were mutation positive on a standard Bruce protocol would have suspicious, but not necessarily diagnostic exercise treadmill tests. But when they brought them back and did what they call the burst exercise protocol, and this is a very elegant, simple protocol. Essentially, they took whatever their highest stage on the Bruce protocol was, and then for the burst protocol, they started them at that stage and just kept them there, you know, same speed, same incline for the whole test, and just had them run till exhaustion. But they would find that they could unmask the fully penetrant CPVT phenotype in many of these patients. And so I've recently started to do this. This is a patient who presented with a cardiac arrest and on no therapy at all. The worst degree of exercise treadmill testing, the worst degree of ventricular ectopy on exercise treadmill testing was just by Gemini, as you see here. I put him on Nadolol, couldn't really make a diagnosis of CPVT yet. He came back with an event. And so I repeated the treadmill test with this burst protocol, and this is actually on Nadolol, but you can see now he has bidirectional couplets here. And so we could actually make the clinical diagnosis of CPVT. We've added flecainide, and then he's actually now in the period where we're waiting to bring him back for his follow-up burst protocol. So I think this is a really interesting question. You know, what is the right exercise test for us to do in patients that we follow with CPVT? You know, the burst protocol appears to be more sensitive. We don't really know how specific it is. And so I think this is a exciting area of new investigation. So with that, I will end my presentation, and I am happy to take questions.
That's great. Thank you, Prince. I'm still waiting for any questions to show up in the chat, but I have a few for you while we're waiting. Do you think there's a role for flecainide by itself as opposed to beta blockers? You mentioned that Nadolol was your first line, but do you ever make exceptions to that?
Yeah, so for the truly beta blocker intolerant patient, then flecainide monotherapy is very reasonable. Again, I find that fairly uncommon in young patients. You know, particularly if we start them very young, we find they can, you know, if you start Nadolol when they're a baby, then they never really complain of side effects as they get older. You know, for the older adolescent who starts a low dose and just feels terrible, then yeah, we can take them off of that. We'll offer left cardiac sympathetic denervation often in that case, but flecainide monotherapy is perfectly reasonable for those small handful of patients.
Thank you. And you mentioned that Nadolol is your preferred beta blocker. Is that just based on its half-life, or is there some other data that you're? Well,
yeah. So obviously it can be used once a day, and it has a long half-life, which is great. But there is a nice sort of comparative efficacy trial from the Norwegian group, I think. That looked at the treadmill test on beta-1 selective beta blockers versus Nadolol. And there's no question Nadolol suppresses exercise-induced ectopy better than beta-1 selective beta blockers. The data on clinical events is, you know, really not strong enough to give a firm recommendation. But yeah, I find it's often a well-tolerated once-a-day beta blocker as well. So yeah, I use it. I use it in CPVT, long QT, regular SVT as well.
And I'm assuming you encourage patients to use it in the morning. I've had some that have come to me taking it in the evening, and I've switched them.
I actually don't have a strong preference. I tell them take it at whatever time of day is most likely for you to remember to take it every day, because that, you know, compliance is the most important thing. So if that's morning, that's great. If it's evening, that's fine too.
And if anyone has questions, please feel free to put them in the chat. I'll ask one more while we're waiting. Does the presence of atrial arrhythmias have any influence on your medical management?
Yeah, so we see atrial arrhythmias improve when we add flecainide often. I personally have not had a patient that has had really problematic atrial arrhythmias, although of course we know they exist in the literature. So certainly if you know, their ventricular arrhythmias are controlled with beta blockers, but they've got symptomatic atrial arrhythmias, then flecainide works really well for those patients.
All right, thank you very much. All right, now it's my honor to introduce Dr. Thomas Paul. He's joining us from Germany. Germany known for its castles, cars, bread, and of course, beer. Dr. Paul's talk is entitled, Cut It Out, Role and Indications for Sympathectomy, and if you're doing it left only or bilateral. Thank you, Dr. Paul.
Yeah, Eric, thank you very much for your nice introduction. So I would like to start my presentation with a quite historical slide, which shows the first application of cardiac sympathetic denervation in a patient with a cardiac channelopathy. That was a report for Dr. Moss and Dr. McDonald in the New England Journal of Medicine in 1971. And they performed the procedure in a 93-year-old woman who was affected with a long QT syndrome, and she was highly unresponsive to a high dose of beta blockers. And in the figure you see on top, the spontaneous QT interval during sinus rhythm, and the next shows you the QT interval after left stellate ganglion blockade by pharmacological blockade. The next one shows you what is quite interesting, the prolongation of the QT interval after blockation of the right stellate ganglion, what refers to the balance and imbalance to the left and right stellate ganglion. And finally, you see the situation 6 months after the procedure with a significantly shortened QT interval, and the patient was asymptomatic afterwards. So this was the introduction of the left cardiac sympathetic denervation into the therapy of patients with cardiac channelopathy. But however, due to discouraging reports on the pharmacological blockade of left stellate ganglion blockade on shortening of the QT interval, this therapeutic modality lost favor despite its proven efficacy subsequently. And it is the credit to the group of Peter Schwartz and his co-workers in Milan and later on in Pavia, who with a lot of animal studies proved that the left cardiac sympathetic denervation did increase the threshold of ventricular fibrillation in the heart, and that there was a lack of denervation hypersensitivity afterwards. And in here you see a publication of the International Registry on the use of left cardiac sympathetic denervation in patients affected with the long QT syndrome. At that time, they were able to collect the data from 147 patients with long QT syndrome. All of them were highly symptomatic. Most of them were on high dose beta blockade. And the result was that this procedure was associated with a significant reduction in the incidence of aborted cardiac arrest and syncope in this high-risk AQT population. And however, that we also saw was that this procedure was not entirely effective in preventing severe cardiac events. However,
sorry to interrupt you. I just want to let you know, we're seeing this in presenter mode. You may want to switch to the general presentation.
Oh, I'm sorry. Okay.
That's okay. Thank you.
Like this? Okay. Is that,
yeah, that's great. Thanks.
Now? Oh, I'm sorry. Okay. So, so the conclusion was that this procedure should be considered in patients with recurrent syncope despite high-dose beta blockade in patients who experience arrhythmic storms who have already implanted the defibrillator. The first application and the first successful use of this therapeutic mode in patients with CPVT was published by Dr. Willi and Dr. Schwartz in the New England Journal of Medicine in 2008. There was a report on 3 patients highly symptomatic with CPVT, despite at that time high dosage beta blocker therapy, where we already also contributed one of those 3 patients. And it turned out that by doing left cardiac sympathetic denervation in these patients, that all of those 3 patients who had significant symptoms before the procedure were symptom-free afterwards. The next slide, you see the exercise stress testing on the left side before left cardiac sympathetic denervation of one of those 3 patients. And what you can nicely see that you see during the exercise stress testing, polymorphic bidirectional ventricular ectopy, and after left cardiac sympathetic denervation, the arrhythmia was not present anymore. All those patients had been operated by open chest surgery, and a year later, the group from the Mayo Clinic from Dr. Ackerman presented their data on the use of video-assisted thoracic surgery, 18 patients with long QT syndrome and CPVT in 2. And again, the procedure was highly effective with this less invasive procedure. We reported our results in 2013, 10 patients, again, 5 of them with CPVT, 5 with long QT syndrome. All of them were highly symptomatic with aborted cardiac arrest, syncope, seizure, symptomatic VT, and appropriate ICD discharges. And after left-sided sympathetic denervation, 9 of them were free of cardiac events during a median follow-up of 2.3 years, and 1 of the patients still had syncopal events. I think the usefulness and the impact of this procedure is nicely presented by this slide. This was one of our patients, 6-year-old boy with CPVT, was at that time on high-dose propranolol and flecainide. On the left end here, you see the memory out of the ICD device. He had a very, very high burden of non-sustained ventricular tachycardia before the procedure, and after the procedure, he was almost entirely without any tachycardia anymore. And this event, what you can see here, was related to the fact that he reduced the medication by his own. There was an ongoing international registry, again led by Peter Schwartz from Pavia, on the use of left cardiac sympathetic denervation and the management of CPVT. It was reported in Circulation in 2015, and it covered a total of 63 patients with CPVT who underwent the procedure. And in the next slide, you can nicely see the incidence of major cardiac events despite high-dose antiarrhythmic therapy before and after left cardiac sympathetic denervation. Here on the left side, you see the high burden, and on the right side, that only a minor part of the patients were still symptomatic. So the conclusion was that left cardiac sympathetic denervation is an effective antifibrillatory intervention for patients with CPVT. Whenever syncope occurs, despite optimal medical therapy, this procedure should be considered and as the next step rather than an ICD, and should complement ICD therapy in patients with recurrent shocks. The next slide shows you how this therapeutic option was already used in the largest study on pediatric CPVT that was published by Rosten and co-workers in 2015. This study has already been mentioned by Dr. Congenital. It covered 226 patients with CPVT. They were diagnosed below the age of 19 years, and they were symptomatic in 78% of the patients. It is of note that more than 50% of those patients had an ICD implanted for primary prophylaxis in 1/3 of them. And what is very, very remarkable, that almost half of them during follow-up experienced appropriate shocks. And in addition, also inappropriate shocks were very frequent in more than 1/5 of those patients. In addition, it is remarkable that there was a poor response to appropriate shocks in 16%. In addition, 23% of the patients suffered from significant complications. And finally, almost 1/5 of those patients suffered from electrical storm, and 3 of the patients finally died despite an ICD implanted. In contrast to this, left cardiac sympathetic denervation had been performed only in 8% of the patients. All of them had been treated with beta blockers, and 3 of them were flecainide. An ICD had been implanted in already 10 of those patients. It is of note that after the procedure, almost 1/3 of the patients became asymptomatic. One patient had still syncope after missing dose of naloxone, and another patient experienced cardiac arrest. It is of note that the left cardiac sympathetic denervation does not negatively impact peak heart rate, cardiopulmonary exercise capacity, or cardiac contractility. This is a report published 2 years ago in JACC-EP, 55 patients with long QT syndrome, and here you see the peak heart rate before, after left cardiac sympathetic denervation. Here you see the peak oxygen consumption during exercise stress testing, and here left ventricular ejection fraction before and after sympathectomy. However, when we consider the procedure, we have to realize that there are significant sequelae after the procedure. On the left side, you see the face of one of our patients, 6-year-old girl, who had a harlequin-type facial flush, together with asymmetrical facial sweating and unilateral hand dryness, which may be present in almost 50% of the patients after the procedure. The Horner syndrome, like this, as you see on the right side, it may be present or has been reported in approximately 15% of the patients. So when we reconsider the usefulness and the side effects of the procedures, there are, as we have learned, a couple of patients that are responsive to this procedure. And when we consider whether it may be, what may be the right way to treat those patients, we have to reconsider the effects of a unilateral stelectomy. On the left, left side of this slide, you see the normal situation with 2 stellate ganglia, and in the normal situation, we have a stronger effect of the left stellate ganglion to the heart compared to the right side. However, in addition, there are efferent sympathetic fibers to the contralateral stellate ganglion that exerts inhibitory effects. So on the right side, you see the situation after left stelectomy. Here you see that we have interrupted the influence of the left stellate ganglion to the heart. However, also the inhibitory effect to the contralateral stellate ganglion is interrupted. So, and the right stellate ganglion has now an increased effect of the heart, because the stronger effect of the left stellate ganglion is interrupted. The net effect is a lower influence of the sympathetic nervous system of the heart, but in some of the patients, this may be sufficient enough, and again, that significant arrhythmias are still present. So, and then it may be discussed, I have hypothesized that those patients may benefit from a bilateral cardiac sympathetic denervation. However, at the present time, there are no comparative studies comparing left versus bilateral sympathectomy in pediatric CPV patients. There are, however, some publications on the use of this bilateral compared to left sympathetic denervation alone in patients with refractory ventricular arrhythmias or electrical storm, like this report from Heart Rhythm Journal in 2014. This is a report of 41 patients, and what you can see during midterm follow-up, those patients who had a bilateral sympathectomy had a better outcome compared to those patients who had only left cardiac sympathectomy. So I would like to summary and conclude the left cardiac sympathetic denervation was highly effective in CPVT patients unprotected by pharmacological therapy and or recurrent ICD shocks. In patients with syncope, despite optical medical therapy, left cardiac sympathetic denervation may be considered rather than an ICD and may complement ICDs in patients with recurrent shocks. The role of bilateral cardiac sympathetic denervation in pediatric CPVT has not been systematically studied yet. And finally, despite the proven efficacy of left cardiac sympathetic denervation, it is probably this therapeutic option is probably still unappreciated in highly symptomatic CPV patients. Thank you very much for your attention.
Thank you very much, Dr. Paul, for that wonderful presentation. Again, for the audience, please feel free to submit any questions in the WOVA app under the Q&A section. We did realize that there are some questions from the previous talk as well, so we'll try and go back to that. But first, I wanted to open it up for questions to Dr. Paul about sympathectomies. While we're waiting for any questions that might come up from the audience, Dr. Paul, what is your opinion about doing the sympathectomies open versus thoracoscopically? Do you find one has better outcomes or and or less side effects, or what's your preference at your institution to do?
At least from a cosmetic point of view, it is, and what the invasive nature of the procedure is concerned, doing it by VLV assisted thoracoscopy, it seems preferable. So we have switched, I think, more than 10 years ago from open to closed. It is my impression that also in the literature, I did not find any comparative studies on even on the usefulness, on the efficacy, and also side effects.
And we do have a question from the audience, and I'm going to kind of add on a little bit to it. The question from the audience is there any data to support removing beta blocker therapy after left sympathectomy? And just a kind of tweak on that as well, would you ever offer a left sympathectomy rather than starting medications?
So the philosophy of sympathectomy is that the patients continue the previous medication at least during the early and mid postoperative period, because those are at least, most of those patients are presented, and the patients from those studies, they were highly symptomatic on high dose medication. So there is no reason, at least during the early postoperative period, to change the medication. And I wouldn't reduce it on purpose.
Great.
CPVT is still the most lethal cardiac channelopathy, and I think the goal is that that the patients become asymptomatic and that we avoid that they develop significant arrhythmias, and especially, as I've shown, if those patients who have an ICD implanted, they have a very high risk to become more symptomatic and to develop electrical storm.
Agreed. Thank you very much. Just so that we have some time to go back to some of the audience questions for Dr. Catecholaminergic, we'll bring him back, and Eric can ask some of those questions before we move on to our next speaker. Thank you so much, Dr. Paul, for your presentation today.
All right, I'd like to apologize for people that we didn't know we weren't looking in the right place for the questions, but we have them now. So I'm going to combine a few of the questions to prioritize time here. I have a few questions about starting Nadolol in young patients. Would you use beta blockers in babies who are diagnosed genetically, even if they have not had symptoms, or what age would you consider starting beta blockers, and do you dose it differently in babies?
Yeah, good question. So yeah, if there's a family member who a patient with CPVT has a child, and we test them and they have the mutation, I do start nadolol in babies, not necessarily in the newborn period. There's no particular urgency, I don't think, but typically when I first see them in infancy, I do just once a day dosing. And I will say that we do see some hypoglycemia with nadolol in babies more, at least in my practice, more so than with other beta blockers. So that is one thing to warn parents about. Usually, if you have to use the higher doses, but I've had some, infants and toddlers that are just on 1 mg per kilo per day that have had symptomatic hypoglycemia. So that is something to be wary of. But yeah, I start mutation carriers, essentially, when I first see them.
Just to be clear, do you start with propranolol first, or you just move right to nadolol initially?
I usually start with nadolol. Certainly propranolol we use a lot in neonates and very comfortable with that. And I think that's a perfectly reasonable alternative to nadolol. So I will say I used to, probably 10 years ago or so, not use nadolol in babies, and I do propranolol for the first year and then switch to nadolol. But now I use nadolol in infancy as well.
Thank you. I have a question about, do you have any experience with ivabradine in patients with CPVT? The question said there were a couple of case reports on adding it in patients who are symptomatic despite beta blockers and flecainide.
Yeah, I have no personal experience with ivabradine and CPVT, but yeah, I've seen the case report. So I think, obviously if you've got them on everything and they're having problems, it's a reasonable drug to try. And
the last question, you mentioned genotype positive but phenotype negative. There's a question about the other direction. So genotype negative but has PVCs or couplets with exercise. Do you think of that any differently?
Yeah. So if they have a clinical diagnosis of CPVT but are genotype negative, I treat them, like a genotype positive patient. They've got the disease, and that's, we have to remember that's still about 30 to 40% of patients that don't have mutations in RYR2 or any of the other less common ones. So that is not an uncommon situation. The only difference is then when you screen the family, you don't have a genetic test to look at. All you can do is do the treadmills. And again, you've got that same conundrum, the family member that has, just single PVCs, but not quite the fully penetrant phenotype. How aggressive are you with them? Again, nowadays, I'd probably consider that burst protocol to see if I can unmask the fully penetrant phenotype, and if they have it, I would treat them with nadolol just like a genotype, an RYR2 carrier, if you will.
That's great. Thank you very much again.
Sure. Yeah.
I'm going to hand it back to Kara for the next introduction.
Great. Thank you so much. I would next like to introduce Dr. Peter Aziz, who is the Director of Pediatric Electrophysiology at the Cleveland Clinic. He is going to give us a talk on CPVT in sports. To restrict or not to restrict, that is the question. Thank you very much, Dr. Aziz.
Thanks, Kara. Give me a second. I'll pull up my slides here. Is that showing in presentation mode or?
Yeah, we're seeing your presentation mode.
Okay, let me swap that real quick. Is that better?
Perfect.
All right. Hello, everybody. And I want to first thank PACES and SADS and Karen and Eric for the invitation to share thoughts with you guys about CPVT in sports. I have nothing to disclose, and we'll get right into it here. I always like to start talks like this with a case just to bring it to a bit more practical of a viewpoint. So this is a previously healthy 16-year-old male. I've known him for quite some time now. I actually saw him this morning. He, when I met him, had exertional syncope twice. Both events were during lacrosse, one during practice, one during a game. We evaluated him suspecting CPVT. He had a stress test that showed complex ectopy. His echocardiogram was normal, and gene testing confirmed our suspicion in an RYR2 gene variant that was classified as pathogenic. His clinical course, he was started on nadolol monotherapy, targeting 1 per kilo per day, which he tolerated. We repeated his treadmill test and found that he had isolated PVCs at peak exercise, was asymptomatic for 6 months at the time we had this discussion, which was, can he play? So using that as a framework and a context, we'll get back to that very question. But before we do, it's worth hashing out what evidence exists in the literature currently. And to be fair about this, there's not much. The one and only paper that I came across, and I'm sure everybody in the audience is familiar with, is Dr. Ackerman's work out of Mayo, entitled Competitive Sports Participation in Patients with CPVT. This was in JACC EP in 2016. And first, I'll start with his definition of a competitive athlete as it pertains to this study. Really, anyone that was participating in activity greater than demand perceived by a Class 1A sport, hiking and aerobic exercise were included. So, as we all know, with the limitations of the framework in Bethesda, we'll talk about that in a second. That's not an all-encapsulating categorization of sports. So there are some sports that live outside of that. So he excluded the Class 1A and included all the sports that were considered a higher demand than that. And the treatment protocol is much like Prince had outlined in his talk, and probably what most of us do, I think, in terms of our protocol. We start with nadolol monotherapy. I think his group started at 1 per kilo per day and divided it BID if they're less than 10 years, something that our group does as well. And then titrated that with exercise testing. If complex ectopy, anything more than couplets was found on exercise, the treatment strategy would be to either increase the nadolol if 1 per kilo was tolerated to 2 per kilo per day, start the patient on flecainide, or perform denervation therapy. And this figure here just outlines his CPVT cohort. So I'll walk through this here a bit. His CPVT cohort consisted of 63 patients in total. Many of these patients carried the diagnosis of CPVT prior to being evaluated by his group. And prior to his evaluation, 32 of the patient population, a bit more than half, were what he described as never athletes, so people that never participated in sports. 7 were former athletes. Those are people that have participated in sports up until the diagnosis. And then there were 3 that stopped participating in sports as soon as they were diagnosed. All of these lumped together after diagnosis into what he terms the non-athlete group, which was 42 patients that were not participating in sports beyond the diagnosis of CPVT. And then 21 of them that were athletes remained athletes after their diagnosis of CPVT. And the idea behind the study, of course, was to compare those two groups in terms of event rates. Slicing this a bit more finely, the cohort of those 63 patients consisted of 46% males. The mean age of patients in the group was 25.7 years. Important to know that the patients that were turned athletes were actually younger, and that was a significant difference statistically. 84% of the patients that had the diagnosis of CPVT had an RYR2 variant. And then 83% were on some combination of therapy listed here, whether it be a beta blocker, flecainide, denervation. 32% had ICDs, though he was quick to note that all of those patients received their ICDs prior to being evaluated at Mayo. Breaking this down into the sports that they participated in, we're all familiar with this classification from Bethesda 36, which uses the static component on the y-axis and dynamic component on the x-axis of classification of sports, with the Class 1A being here at the bottom left and increasing up and increasing to the right. And you see here there's a relative well distribution of different categorization of sports participation, where there are 20 unique sports and 21 athletes. So there are some athletes participating in more than one sport. 90% were participating in either a high static or high dynamic sport group. So on the upper or the rightward rows columns of this group, there was 1 NCAA athlete and 1 professional athlete that were included in this study group. And what he found was that between the athletes and the non-athletes, both of them had a comparable event rate when followed over time. And what I found very interesting, and we all know this clinically, when he compared this to his long QT athlete incident group, it was much, much less. So the CPVT patients are much more likely to have events, whether they're athletes or non-athletes, compared to the athletic group and the long QT side, which is an important point that we'll get back to. And our group at CHOP showed really the same occurrence risk of events in our long QT group in sports. Looking at a Kaplan-Meier curve where on the x-axis is time to events, we found that really the non-athletes and the athletes had a similar time sequence in terms of when they had their events. So there's really no measurable difference there either. In his discussion, it's mentioned that at earlier age of diagnosis and higher rates of events in patients who are active prior to diagnosis, the ever athlete group. However, this difference disappeared when patients were treated optimally. So in other words, the patients that were athletes before they were diagnosed were much more likely to have events than the patients that were not athletes, though after diagnosis with appropriate therapy, as mentioned before, that really converged to no difference at all. Suggesting, of course, that a treated patient it has the same probability of recurrence, whether they're an athlete or not. So how does this translate into guidelines, and what do the guidelines say? Again, this is another paper that we're all familiar with, which is a AHA/ACC scientific statement published in Circulation in 2015. This was the next edition of Bethesda 36 for all of us, what we all call the Task Force 10, which addresses the cardiac channelopathies. Again, a paper that was written by our colleague, Mike Ackerman. And he first starts off as a blanket statement, more or less, when we're dealing with ion channelopathy patients in sports. These measures really need to be taken for everybody, regardless of what their perceived risk is, which is one, emphasizing that electrolyte hydration, replenishment, and avoidance of dehydration is paramount. The acquisition of the personal AED as part of the, quote, sports safety gear. So in your bag with the helmet and the elbow pads lives an AED. And then third is establishing an emergency action plan, where this is mentally or even physically rehearsed what to do if Joey has a syncopal event while they're playing sports. Where is the AED? What's the action plan? I think is something that's very nice to think about, obviously, before it actually happens. The recommendations a bit more specifically are as follows, and I paraphrase. First is see a channelopathy expert. So be in the hands of somebody that is considered an expert in the field dealing with channelopathy conditions so that treatment is optimized and care is optimized. The next is a patient that is considered eligible has to be treated and has to be asymptomatic for 3 months. So regardless of the disease, regardless of genotype, phenotype, regardless of perceived risk, a patient has to be under therapy and asymptomatic for that portion of time. For our channelopathy patients, they're essentially green lighted, in other words, not restricted if they have concealed disease, which is to say they're gene positive but phenotype negative. And then specifically for our CPVT patients, and I'll read this, an athlete with symptomatic CPVT or an asymptomatic CPVT athlete with exercise-induced PVCs and bigeminy couplets or non-sustained VT. Participation in sports is not recommended except for the class 1A. Another way of saying that is if you have the CPVT phenotype, then you are sidelined to the 1A. And this reads very differently, of course, than the other channelopathies discussed in Task Force 10. So I'll place some of my own personal editorial comments here. This is not my own, of course, and I think we all practice this probably in different ways. But as described by the ASA in 2017, there's the SHARE approach, which is a platform of shared decision-making. Again, this is all something that we practice I'm sure very frequently, but it's the process of pros and risk, having the discussion, assessing the adjudication of how important sports is for your patient. All of these things are really paramount to the discussion and different for every patient that we see. And the caution, that that I would argue for is the echocardiogram is important in this disease. In most of our channelopathy patients, at least in the long QT group, the echocardiogram is typically normal. It's not something that we repeat or pay particular attention to in somebody that's not having a high arrhythmia burden. Whereas in CPVT, there can be concomitant LV disease. This is a patient of mine that has an RYR2 gene variant and also carries the LV non-compaction phenotype. Fortunately, his cardiovascular function, LV function, is normal, though this is something that we've kept an eye on. Any progression of LV disease, of course, adds to risk here. So something that we have to keep in mind as it pertains to sports participation. And of course, we're dealing with teenagers, and in the teenage world, we know that non-compliance is not something that we can control. And unfortunately, in CPVT, non-compliance is very unforgiving. So unforgiving, in fact, that many of our patients that are not compliant, and I have one that wasn't, don't survive, which is, of course, tragic, but something that needs to be injected into the conversation that we have to be practical about. So back to our patient. This was our lacrosse player, and I'll dissect this decision here. We talked about our shared approach. This patient has a healthy heart, as we discussed. His echocardiogram is normal. He wasn't a very good lacrosse player, which can or can't be injected in the conversation. And he decided to not play. That was his own volition, and by strong influence by his mother. And we're all very close to this day. Again, this is a patient I saw today. And that made me very, very happy, because then the onus is no longer on us. And certainly my own bias in this conversation, I'm sure, influenced his decision. This is a picture of me, of course, after Michigan beat Ohio State. So the key takeaways here are one, emphasizing autonomy, and two, empowering our patients, recognizing that there is risk, and obviously there is, looking at the echocardiogram and making sure that non-compaction disease is not part of the phenotype. And then finally, understanding that CPVT and long QT syndrome are not the same disease as Dr. Paul had recommended. CPVT is the most brutal of channelopathies, and I think therefore is due some respect in terms of the sports equation. That is all. Thanks everybody for your attention.
That was excellent talk. Thank you very much. Despite people knocking on your door, you've continued to talk right through it. That was great. And you showed a picture of yourself wearing suspenders, I think, which I'm not sure what that was all about. But all right, we're cutting it close on time. So I am going to skip ahead to the next speaker. Our next speaker is Dr. Jennifer Avari Silva. She's joining us from St. Louis, Missouri. St. Louis is the home of the Gateway Arch, Stan Musial, and the St. Louis Cardinals, and the birthplace of the ice cream cone. Look it up. It's true. At least from Google. Her talk is entitled Loop, Here It Is, How and When to Use an ILR in CPVT Patients.
Thank you so much. Let me get this screen pulled up. And hopefully you are seeing my screen. We can get started. Thank you so much, SADS, to Eric and Kara for the opportunity to speak today. And I'm going to be speaking about loop recorders and their role in CPVT. I do have the following disclosures, but none of which are relevant to our talk today. I'd like to start with the case presentation as well. I'm going to talk about a patient, GT, and this kiddo presented to our clinic at the age of 7. His complaints included 2 episodes of dizziness with exertion, but no overt syncope. He had a negative family history, and his mom is a NICU nurse, and this is going to become important in the rest of his story. His presenting EKG was not terribly impressive. He did have a bit of a borderline QT. I suppose people can fuss at me about his T waves, but really he was in sinus rhythm. And At that point, he was given no activity restrictions and recommended to follow up in about 1 year. He presents to the ER less than a year later and says that he had a syncopal event at school. He was playing soccer and he fell on the field. The mom, remember, a nurse, reports that the child was unconscious for about 45 seconds, and she reported that he wasn't breathing, had no pulse, and that he was blue. She started CPR, and after a few compressions, the child came to. The ED actually did a really nice job and did a thorough history, and it turned out that he had had an event the previous month when he was at the pool and he panicked. He was trying to get his goggles on in place, couldn't quite do it, and passed out on the pool deck. Now, this is where the story gets interesting. He was actually sent home from the ER to follow up with cardiology the next day. My reaction. So let's see what his workup actually showed. He had serial EKGs, which really all showed sinus rhythm with pretty normal QTs. He had an echo, and I agree with everything Dr. Aziz said. In this particular substrate, echoes are very important. He had a normal LV size and normal systolic function. The child ran on an exercise test. He was 8, but still was able to do it. He had a normal study with normal QT shortening and no inducible arrhythmias. He had a Holter that was normal, chest x-ray that was normal. We ordered a cardiac MRI that was normal. He had a neurology evaluation, and they felt that his events were not consistent with seizures. We ordered genetic testing, and just because this story was not totally right, we put in a loop recorder within days of his presentation to the ER. In October 2013, he was at school and during recess had this event. This was about 4 weeks post-ILR implant. Now, to be clear, the patient had no syncope with this episode, and it was only with very intentional questioning and prodding that he admitted to maybe feeling a little funny. Maybe he had to stop while running at recess, but nothing was bothersome enough to tell his teacher, or importantly, his parents, that something had happened at school. So when we got this transmission, we said, well, that's great. You're admitted to the hospital and we're starting Nadolol. And then, of course, his genetic test results came back within a few weeks later. This was a while ago, and this patient has subsequently undergone 2 more insertable cardiac monitors since that time. And interestingly, in 2019, was diagnosed with some non-sustained atrial tachycardia on his ICM. Notably, he was asymptomatic with his atrial tachycardias as well, but we took that as an opportunity to optimize his medications and added flecainide to his Nadolol. And since then, he's done very well. Now, we all know that these insertable cardiac monitors are limited in lifespan and last for about 3 years. And so every 3 years, we keep asking, what's the story? Should we put in a new one or should we take it out? And every time we talk about this, both the patient and his parents say they want to keep the ICM. And when we ask why, it's very clear. It provides him and his family a sense of comfort that someone, namely me, is watching and monitoring him. So what's the data and evidence? Well, insertable cardiac monitors, as most of you well know, have undergone rapid evolution in the technology. Generation 1 devices, which were the original implantable loop recorders, were a bit of a bigger procedure. They required a proper pocket creation. The devices were larger. An example here in this image is the Reveal XT. In about 2014, we saw the insertable cardiac monitors, or the 2nd generation devices, come to the market. And these were truly insertable devices and were markedly smaller than their predecessors. They had a 6-fold reduction in device volume and a 5-fold reduction in device weight. And if we look at this side-by-side comparison of generation 1, the Reveal XT, to generation 2, and I've just for the sake of comparison put here the Reveal Link and the confirmed device, we can see that the volume has gone down from 9 cc's to 1, maybe 1.5, and the weights are down from 15 grams down to 2 to 3 grams. And the devices remain very smart, with the ability to both record symptom and auto trigger events. I believe that ICMs have an increased usability compared to even their predecessor ILRs. ICMs do have a shorter implant procedure and faster recovery times after their implant. And anesthetic use has reportedly changed as we've moved from generation 1 to generation 2. For the generation 2 ICMs, there's an increased use of conscious sedation. And then, of course, some general anesthesia and local anesthesia. The ICMs retain their diagnostic utility in line with the ILRs and have a diagnostic utility of about 50% plus at 2 years and up to 80% by 4. Complication rates are low for both types of devices. And in our population, we have found an average time to diagnosis between 38 weeks to 55 weeks. So long-term monitoring is in fact helpful. In our institution, we actually looked to see what our use of these devices were year over year. The orange line represents the second generation ILRs and the blue is the first generation ILRs. And 2014 was when we institutionally shifted from generation 1 to generation 2. And what we've seen is a real exponential increase in the use of ICMs since we've gone to generation 2. So how about what is the data on the implantable loop recorders in patients with inherited arrhythmia syndromes? And in 2016, we published our data on this. The aim of our study was to categorize the findings of continuous loop monitoring and the impact of these data on the management of patients with all inherited arrhythmia syndromes. And for the purposes of today, we're really going to pull out the CPVT cohort. So this was a retrospective review. The data was collected between 2008 and 2015. And we had 20 patients, 9 of whom had CPVT. So we're going to focus on those 9 patients. Just notably for inclusion, these were children with either known or suspected inherited arrhythmia syndromes. For most of the CPVT patients, we had genotype positive. What was really interesting is that automatic transmissions occurred very frequently in patients with CPVT. In fact, 81% of all the automatic transmissions in our study occurred in patients with CPVT. And importantly, 21% of these transmissions yielded actionable data. So let's take a look at that. In 4 patients of our 9 with CPVT, we had actionable data. What did that mean? We either saw polymorphic VT, atrial tachycardia, pauses, bidirectional VT. And really the most common intervention was medication adjustment, whether initiation, titration, or addition of medications. In one patient, this patient right here, we actually had to explant the loop and implant an ICD. About symptom events. Symptom events were also pretty common, with 51% of all of our symptom events occurring in patients with CPVT2. Now, what's interesting here is that a lesser percentage, only 12% of these transmissions, yielded actionable data. Let's look at this. So these are the patients in the red boxes who had actionable data. But what we found was that the rhythms that were being documented was a lot of sinus tach, ventricular bigeminy, isolated PVCs, and only in 2 cases did we have a documentation of non-sustained torsades or bidirectional VT. So what did we conclude from this study? That loop recorders in patients with known or suspected inherited arrhythmias may be useful in guiding medical management. And most often what we were seeing was an escalation in medical therapy. And importantly, many of the symptom events we were seeing represented normal or benign rhythms. And this was really important for patient and provider reassurance that no further intervention was needed. Interestingly, we think that the patients with CPVT have subclinical arrhythmias that were automatically triggering the devices and sending that data for us. And that may be important in ongoing management. So we believe that ILRs should be considered in inherited arrhythmia syndrome patients who do not meet criteria for an ICD, particularly in the CPVT subgroup. So what does it look like now in our institution? Well, like I said, we've been looking at our data. And when we compared our first generation to our second generation ICMs, we've seen that the inherited arrhythmia syndrome population was 5% of our Gen 1 and is now 24% of our Gen 2 population patients. I want to talk about the 2021 PACES consensus statement and guidelines on CIEDs, and specifically look at the guidelines regarding ICMs. There are two new guidelines in this document specifically related to ICMs and patients with channelopathies. The first is a 2A recommendation that ICM implantation is reasonable for guiding the management of patients with cardiac channelopathies or structural heart disease associated with significant rhythm abnormalities. The second is a 2B guideline. This one states that ICM implantation may be considered for detecting subclinical arrhythmias in patients with cardiac channelopathies or other conduction diseases associated with significant rhythm abnormalities. I think this is important because it gives us as providers an opportunity to talk to our patients about the potential utility of ICMs in their ongoing care. I wanted to provide a quick thought about wearables because everybody is now talking about them. We have an increase in the quantity and type of wearables, particularly the direct-to-consumer wearables, ranging from everything from the AliveCor monitor, the Cardia monitor, to Apple Watch and Withings watches. What's important about these technologies are they provide on-demand ECGs, and some of them may also provide background assessments of heart rate and trends, but they don't provide information on rhythm. Now, I think that wearables actually have a very important role in patients who are very symptomatic and who have a process that has a low lethality. But what we saw from our data in the loop recorders in the CPVT patients was that the automatic triggered events were often diagnostically relevant. So I'm not a big fan of wearables in CPVT patients as a single source of data. In conclusion, I believe ICMs provide an additional tool for patients and providers for long-term remote monitoring and are of particular utility for CPVT patients. That CPVT patients have an increased number of automatic transmissions compared to other inherited arrhythmia syndrome patients, with 21% of those transmissions resulting in actionable data. That the utility of automatic transmission data may limit the types of other usable devices in this population, and that's specifically in regards to wearables. Current guidelines support the use of ICMs to guide management or detect subclinical arrhythmias, and that careful discussions and shared decision-making, like Pete was just talking about, is really important when deciding if these devices are indicated for your patients. Thank you.
Thank you very much for that excellent presentation. We are running a little bit short on time, but I just wanted to ask one quick question before we move on to the debate. Given the high number of subclinical arrhythmias that you guys found, particularly in the CPVT patients, do you think all CPVT patients should get one?
We don't necessarily put them in all CPVT patients, but I have conversations about it early on with all families, so they know that it's a technology that we may be talking about being relevant for their kid. And what I find is that families will often go away and then come back and say, you know, we talked about that, and I don't know that we're ready for it, which is fine because I may not be ready for it. And then I have a handful that come back and say, you know, we actually really think this might be very important and useful for our child. So I will often bring it up as part of the early part of the conversation as to the types of monitors that might be in their child's future, not necessarily when it's time to put it in, but just sort of in that big, you know, those big conversations you have early on where you're talking about everything from sports to when do they get an ICD, if they'll get an ICD, what this means for their future family planning. I throw it in there in that discussion. And I find that patients will, I have a lot of CPVT patients who've come to me and said, I really like that loop recorder, and then want it to be explanted and then re-implanted when the battery runs out.
Great.
Thanks for
Thank
the
you so
question.
much. Yeah, excellent. Thank you. So we are going to move on now to the much awaited debate for today. And our moderator for the debate is going to be Dr. Raina Tan. She's an assistant professor in the Department of Pediatrics at the New York University School of Medicine. And our other debaters are going to be Dr. Scott Seresnick, who's an associate professor of pediatrics at Stanford University, and Dr. Shu Sanatani, who's professor of pediatrics at the University of British Columbia. So I would like to invite them all to come on, and Dr. Tan, you can take it away.
Thank you so much, Kara and Eric. I'm gonna start sharing my screen. Do you guys see my screen yet?
We see your PowerPoint.
Hold on. Like 2 minutes. Okay, there you go. Do you see it in presenter mode now?
I know we still see just the PowerPoint with your slides on the side and.
Better?
Yes.
Okay, awesome, great. So we are gonna start the debate, and our debate will be on all newly diagnosed patients with CPVT who present with a cardiac arrest should have a secondary prevention ICD. And before we start the debate, we are actually gonna have a poll for our audience. So the question will be, should newly diagnosed patients with CPVT who present with cardiac arrest have an ICD for secondary prevention? And the options are, yes, an ICD should be implanted in combination with pharmacologic therapy plus minus a sympathectomy, or no, we should first start and maximize pharmacologic therapy plus minus a sympathectomy prior to considering an ICD implant, or you're not sure. So for our audience members, if you could go to your Vora app in the polling section to cast your vote, we will give everyone about a minute or so to cast their votes. All right, looks like we only have 5 answers. We still have about 30 seconds for anyone in the audience who wants to vote.
I think a group this technically challenged should maybe not be looking after ICDs. 7 votes in 1 minute.
There's 10 more seconds.
I may have to call some election fraud here too. I don't know.
All right, I'm gonna give it a little more time to see if more people want to answer, but if not, maybe some people need convincing from Scott or Shu. All right, well, that's about a minute. We have 10 answers, but it looks like 50% will say that they will not put an ICD at this time. All right, so before we go to the All right, before we start the debate, I just wanted to go over some of the prior guidelines we have on CPVT and ICD implantation. So we'll start with the 2013 guideline from Heart Rhythm. And here you see that it's a class 1 recommendation, ICD implantation for patients with CPVT who experience cardiac arrest or recurrent syncope or polymorphic VT despite optical management. And they go on to say in the discussion that in patients who have experienced an aborted cardiac arrest before initiation of therapy, that beta blockers or a combination of beta blockers and flecainide should be started plus an ICD. So this was in 2013, and there's a 2017 guideline from the AHA, ACC, and HRS. And here they gave a class 1 recommendation for patients with CPVT and recurrent sustained VT or syncope while receiving adequate or maximally tolerated beta blocker. treatment intensification should either be a combination of medical therapy, sympathectomy, or an ICD. But then when you go on to the discussion, they do say that ICD implantation in patients with CPVT should be reserved for patients with prior sudden cardiac arrest, as the debate is about, or in patients with refractory ventricular arrhythmias on combination medical therapy. And then we'll go over the new guidelines. So the 2021 PACES expert consensus statement actually divide this up a little bit and give a class 1 recommendation for ICD implantation in patients with a diagnosis of CPVT who experience cardiac arrest or arrhythmic syncope despite maximally tolerated beta blocker plus flecainide and or sympathetic denervation. And then they put down as a 2A that ICD implantation is reasonable in combination with a pharmacologic therapy with or without the denervation if aborted sudden cardiac arrest is the initial presentation. So basically, if that's the initial presentation, that it's reasonable to actually just try pharmacologic therapy first prior to ICD implantation. So with that, I am actually going to hand it off to our pro, who is Scott Sarasnak.
Thanks, Serena. Hopefully everyone can see my slides in a minute. Thanks, Eric, Kara, SADS, everyone for inviting me. Hopefully you guys can see my slides okay. So I have the pro position and I have no disclosures. I will say it's an honor to be debating Shu, who is a true triple threat, actor, producer, director, and electrophysiologist as well. So it's an honor, Shu, to be debating you today. What I'm not going to argue today in terms of ICDs and CPVT is that we should put ICDs in for a new diagnosis, a genetic diagnosis, a family history of sudden death, any primary prevention indication, or ICDs without medical or other therapy. I'm not going to argue any of that. What we are talking about is the patient who had cardiac arrest, the patient who suffered VF, was resuscitated, and almost died. And I think it's important to sort of step back and say, why do we place secondary prevention ICDs in the first place? Well, we do know that there is data on randomized controlled trials in thousands of patients that secondary prevention ICDs decrease the risk of arrhythmogenic death. And in this large meta-analysis, ICDs brought about a 7% absolute reduction in arrhythmic death. And it's important to remember that the number needed to treat is about 15 ICDs to prevent one death at a mean follow-up of 2 years. And we know that this data also is true in children, that in this series of over 100 patients who had a sudden cardiac arrest, that the likelihood of sudden cardiac arrest, again, is very high. And this is almost 20% of patients had an event. So we do know that episodes happen once, they're likely to happen again. And so I really want to argue at 4 points why we still need ICDs in CPVT. And the first point will be that the event rate is high, and that event rate is VF that I'm talking about. The second point is that the data on alternative therapies alone is really not strong enough. And we'll go into some of the details there. Number 3, and people brought this up nicely, is that children and teenagers are often not compliant with medical therapy. And then number 4 is that there are some limitations in the data on risk of ICDs. So let's talk first about the event rate. And I'm going to really focus on the event rate being VF, right? So in the Christine Miyake paper with 24 patients with CPVT, 40% of them received an appropriate shock. And it's really important to note that a third of those patients had VF with 100% successful shock rate in these patients. And of those patients who received an ICD for secondary prevention, almost 60% of them had VF and received an effective shock. So we do know that the event rate is high. And the event we're talking about here is not VT, we're talking about VF. But there is a significant risk of VF in these patients going forward. And looking at the significant meta-analysis that Shu and others did, treatment failure was high. 25% of patients experience a medication treatment failure, and 40 of those patients experience another cardiac arrest. So we do know that the event rate of VF and cardiac events in CPVT is very high. So let's talk a little about the role of beta blockers and FLEC, and just talk a little bit about how the data is not strong enough. Now, Prince gave a great talk earlier. This fantastic paper looking at a true randomized crossover trial of use of flecainide was a fantastic paper, and really kudos to him and the rest of the people who were part of that trial. There's only 14 patients, and I do want to point out that the primary endpoint there was a reduction in ventricular ectopy. It was not a reduction in sudden death or VF events. And 2 patients in that series who had ICDs got appropriate therapy for those for ventricular arrhythmias, and both patients who got appropriate shocks were on flecainide. And we do know that even on medications, the event risk after the diagnosis of CPVT is high. In this series by Shu, which is another great paper, 50% had events on beta blocker or FLEC alone, and still 10% of patients had an event on beta blockers and FLEC plus or minus sympathectomy. So we do know that the risk is still there, even with adequate medical therapy. And so if we talk about sympathectomy, and Thomas Paul gave an awesome talk on sympathectomies, in this series with 18 patients who had CPVT and had sympathectomies, there were 4 treatment failures, including 1 cardiac arrest. So we do know that events can still happen with sympathectomy. Pete actually brought this up nicely, and it was a great segue into my discussion about how teenagers are just not always compliant with medical therapy. And that's across the board, from cardiology to other diseases in pediatrics, with adherence rates anywhere from 10 to 89% for patients with chronic illnesses. And we do know that that is true in CPVT as well. And some of the data shows that non-adherence in this series, 53 of the patients here in this series had treatment failure associated with non-adherence. And we do know that this non-adherence is a problem, and that among patients who experienced a cardiac event after their diagnosis, 10 of this 130 were non-compliant. So we are kidding ourselves a bit if we think our patients are always taking their medicines appropriately, especially when the risk is here of VF and cardiac arrest. And then finally, my item 4 here is the data on the risk of ICDs does have limitations. And this large series on CPVT patients, almost half of the patients had ICDs for primary prevention. And there really is no data on ICD programming. And we do know, we just published recently on our probably the highest risk group of receiving inappropriate shock, infants and toddlers, no inappropriate shocks in 5 years, if we're programming for VF, high detection zones, long detection intervals, close remote follow-up, good rhythm discriminators, dual chamber devices to look for atrial attacks that you see in CPVT. So we can try to do a better job programming around inappropriate shocks. So I can imagine a world where we're talking about Scorsese, Spielberg, and Sanitani. And I can imagine a world where we're talking about CPVT and cardiac arrest not equaling ICDs. Unfortunately, that day is not yet today. So I would really argue that secondary prevention patients with CPVT obviously need beta blockers and not alone. I think there's really a good role for flecainide and sympathectomy, but we also need a carefully programmed, closely followed ICD because their risk of events and VF is very high. Thank you.
Thank you, Scott. All right, Shu, now it's your turn to give us the con.
Shu, you're muted.
Shu, I think you're muted.
Right. Yeah, I haven't said anything yet, but yeah, thank you, Scott. I appreciate your using many of our studies to make your point. It's like when your kid turns all your wisdom back at you. So thanks for setting this up nicely. Obviously, I completely disagree with this preposterous suggestion about newly diagnosed patients with CPVT who present with a cardiac arrest having secondary prevention ICDs. I do have a couple of disclosures. I've not worn a tie for a very long time, so congrats to all of you, Peter, Aziz, Prince. You guys look fantastic. I'm in scrubs. I may or may not be wearing sweatpants and sneakers. I do hold research grants dealing specifically with CPVT. So that is a bit of a disclosure I thought I should make. Now, often in a debate, it is my nature to kind of tear down the guy a little bit, the countering opinion, but in Scott, it's just not reasonable. This is a very nice guy. I can't tell if this photo is from now, his childhood. All of his photos look exactly the same. He's always smiling and just a happy guy. This was, substantiated by what the fellow said. Dr. Sresnak loves putting devices into children, and every fellow knows that this guy is happiest when he's just putting that hardware into that little guy's chest. He thought he had stumbled onto something really amazing. He noticed that these MRIs in all his CPVT ICD patients looked really weird. He was, getting excited that this was going to be the whole of Ceresnac, but then he realized this was actually just artifact and not actually a real thing. Okay, so enough sort of clowning around. Sorry, Scott. Haven't been around people for a long time. So I think we all know, exercise or emotion-induced syncope or even cardiac arrest. Now, these are very young patients. They're around 10 years of age in a few of the series. But 1/3 of patients do experience a life-threatening event prior to treatment. So this is a real, I think this is a good conversation to be having, and we could see by the pre-survey that we don't have a clear direction on this. Now the guidelines, and thanks Raina for setting that up. The guidelines are very clear. The European guidelines, despite optimal therapy. So that's the key statement here in 2017, while receiving adequate or maximally tolerated beta blocker. So there's really no role to go straight to ICD if you haven't tried the beta blocker and or flecainide. Now, this concept of and or is always a bit tricky to know what to do with that in a guideline. Now, Mike and Molly, pictured here, sorry, I couldn't resist. They've come up with a pretty nice document. They've dropped the recommendation from a 1 to a 2A and used some fairly non-committal language, reasonable, may be considered. So I think even they are, not sure about this. Now, what is optimal medical treatment? And, Prince did a wonderful job of setting this up for us. Nadolol, preferably 1 to 2 milligrams per kilogram per day. And I have a very low threshold for adding flecainide and reducing the nadolol. That may not be the right thing to do in a very malignant case, but I have seen the stress test improve significantly with flecainide. And then the important thing really is lifestyle counseling. And it's not activity restriction, as Pete showed us. You have to work with systems to have pill reminders. These kids, they have to own the responsibility. The parents can't be the ones that are, nagging them. That falls apart very quickly. And so non-adherence, which we've talked about a few times today, that's not a reason to have a defibrillator. It's a reason to work with the patient. And, I guess the defibrillator, when you skip your medicine, there's a painful reminder of why you need the medicine. And we've already talked about Prince's excellent study with, yes, a small number, but very good methodology. And really his conclusion, flecainide plus beta blocker significantly reduces ventricular ectopy. So to me, this is optimal medical therapy. Now, there is actually very good data about the specific question that we were posed. And this is Christian Van Werf's paper, Van der Werf, and he looked at this group of 136 patients, 79 of whom received an ICD. Now, the sudden cardiac deaths occurred only in the ICD recipients. Now, these are small numbers, of course. The important thing here highlighted in red, and this is probably one of the most important things to remember, is that appropriate shocks do not equal, lives saved. And in this condition in particular, where we know that there can be self-limited runs of ventricular arrhythmia, it's very important to not overinterpret appropriate shocks. And the one thing that Scott and I will definitely agree on is that these devices require nuanced programming by people who are expert in CPVT. Christina Miyake's paper made that very clear. Now, even in this series, these patients are not on optimal medical therapy. 6% weren't on beta blocker, or 5%, and only a third received either flecainide or denervation. Now we know, and thankfully, the reality of this is that when the stress is withdrawn or diminished, the rhythm normalizes. And Leonhardt's paper, this is one of my favorite quotes, children very quickly learned how to avoid the stress that might trigger the lightheadedness. Now, if you've got an ICD that shocks you, you may get an adrenergic surge at a time when you've already stopped doing what was bringing on the arrhythmia. So the data to date really, I don't think, represents optimal medical care. There's a very low uptake of flecainide. Beta blockers, other than nadolol, are used commonly. Nadolol appears only in 30 to 40% There's a manuscript coming which will confirm that Nadolol is the best beta blocker, and denervation really hasn't been taken up. And then non-adherence is a problem whether you have an ICD or not. So we have to just stare non-adherence in the face. This is some data that we presented last year. Even when we're talking about primary prevention, there's no survival benefit with defibrillators in CPVT. Now, there are some specific concerns with CPVT. These patients take a while to get diagnosed, so they're out there, so they may receive a defibrillator before we actually know their condition. Atrial arrhythmias can complicate, and the occurrence of inappropriate shocks is very high. And ICDs, like Scott's data, that's old white men. These devices are not designed for the active kids that are growing and doing all kinds of things. So as we've already talked about, the potential for harm is very high. And recently, again, van der Werf and Arthur Wilde wrote the editorial to this. This is a tragic case where a single chamber ICD gives an inappropriate shock during AFib, which of course occurs in these patients and resulted in an electrical storm. So they wrote in their editorial, basically, the title of which is Avoid the Risk by Not Implanting Them, the lack of evidence and considerable harm, primum non nocere, so first do no harm. So I will stop there and stop sharing my screen. Thank you from Scott. See, I told you he looks the same in all the photos.
All right, thank you, Shu. All right, I'll give it back to you, Scott, for your rebuttal.
Great, thanks. I'm going to share my screen again. And I think what Shu failed to disclose is he's in scrubs because he just finished an implant of an ICD for a secondary prevention CPVT case. So probably failed to mention that. And I did joke about your directorial debut, Shu, but it was great. If anyone hasn't seen his video, it's actually really excellent, really well done. So a couple points to make. First of all, none of the ICD studies in CPVT are randomized, and there's significant selection bias in those patients who got ICDs and who didn't, and none are powered to show a difference in events. And so the slide you just showed, right, I busted out my statistics book, and really to detect an event rate difference of even 3%, you need over 1,000 patients, right? To detect a 5% difference, you need almost 1,000 patients. So none of these studies are really randomized or powered to show an effect. And let's talk about the van der Werf paper, which is really important, really shining light on the troubles that can happen with ICDs in patients with CPVT. So let's go into the detail, the nuts and bolts here. So as you pointed out, 3 patients with ICDs had a sudden cardiac death event, where none without ICD patients, none of them had an event. However, let's look at those 57 patients. 22 had an implant during follow-up. So a third of those patients had an ICD. Are these really non-ICD patients? 9 of those patients had appropriate shocks. The other pretty incredible thing about this too is 9 patients experienced sudden cardiac arrest. Amazingly, none of them died, but 3 of them actually had an appropriate ICD shock. So half of the patients in the non-ICD group actually had ICDs, and 16 of those patients in the ICD group also got appropriate shocks. And so were these shocks for VF? We're talking about VF is what needs to be treated here, not VT, and we need to program around VT. Were any of these shocks for VF? I don't know, right? And so how many of these patients may have died? The answer is we don't know. And so ICDs really are important for these patients. We have to be really careful, I think, about interpreting this data and saying we shouldn't put ICDs in these patients. Now let's talk about our pediatric patients. So they did look at subgroup analysis in those patients who were less than 14 years of age. And the authors rightly pointed out that perhaps they hypothesized that the younger children could have a higher event risk. And perhaps medication non-adherence and other things could lead to more events in children. And that was the case. Indeed, that was the case with a hazard ratio of almost 13 in patients less than 14 years of age, where those patients over 14, hazard ratio is only 4. So I think we have to be really careful interpreting this data and saying that ICDs aren't needed based on this data in part. So bottom line, Shu, I agree that a shock does not equal potential life-saving CPVT, that we need to think about shocks way beyond VT, thinking about VF in these patients, that there are risks with ICDs that we need to be really careful about, that FLEC and sympathectomy can really be important therapeutic options in CPVT, but VF event rates in this population is really high, even with appropriate medical therapy. And that we need to really be careful about how we program our ICDs to avoid VT storm and think about programming high VF zones. And I would say that the data on alternative therapies for ICDs for secondary prevention is really just not yet strong enough to completely replace something that we know is a proven life-saving therapy. Thank you, everybody. I appreciate it.
Thank you, Scott. All right, back to you, Shu, for a 2-minute rebuttal.
All right. Well, thank you. I think Scott may have shown this. Now, this important series highlights one of the issues, and really this study, which had over 100 survivors of sudden cardiac arrest, the ones that were eventually diagnosed with CPVT, which was 15 patients, only 6 of them had an exercise test, and only half of those being positive. So you can see that at least 9 of these 15 patients, and maybe 12, are not actually diagnosed. And so, of course, they're going to end up with a defibrillator because of the rapidity with which we sometimes treat these patients. And CPVT, was a common late diagnosis. So, and the authors comment on the importance of a comprehensive test. Now, I don't want to make this. I don't want to make this personal. We are, after all, neighbors, and Scott and I more so than some. So we have to try and get along. But I will say, here's a real Canadian case. So this kid, he lived in the middle of the mountains, and he has a witnessed cardiac arrest on a school trip. Now, this guy, interestingly, was a competitive downhill racer, both bikes and skis, and he was really full on. He, competed to a level where he actually was able to break his femur, which I guess is not that hard if you're going 60 miles an hour. But what this does is you think there's no way that this active guy could have CPVT, but that bias is something that we have to guard against, because you can clearly present at 16 or 12 or 18. Now, this guy, he had quite a pulmonary insult, and so he couldn't do a proper treadmill. We discharged him with an AED and said, take it easy, no racing here. And then he came back and then had a very typical stress test. So this is a harder path, especially when the kid is sitting there, the parents are worried, and you don't necessarily have the language to say it's going to be all right. And then subsequently, he had a ryanodine variant. Now, this patient still has no defibrillator. He did get an ICM, and he's back to downhill racing. And again, I emphasize the importance of conversations with these patients and the importance of medication compliance. So he knows that if he misses his meds, he's not out on the ski hill or the bike track. Now, again, we don't want to make this, somehow say that Americans are different from the rest of the world. We definitely don't want to say that these days. The number of ICD implants per 10 ICDs implanted globally is about 4.5 out of 10. So almost half. The population of the States is about 9 times. So some quick math, their population is 9 times, but they put in 22 times as many defibrillators. Now, of course, we're an impoverished, health care system. But again, non-evidence-based ICD implantations in the United States is a big issue, and the rapidity with which some of the treatments are issued is a concern. So thank you very much, everyone.
Thank you so much, Shu and Scott, for both those wonderful videos and pictures, but also for putting your case out there. I am actually gonna have everyone do a post-debate poll. It's gonna be the exact same question. If you can go back to the Vora app on the polling section, hopefully we'll have more than a couple of people vote this time. So same question. So after hearing both Dr. Sanatani's and Dr. Saresnak's arguments for either side, which one would you do now? Would you still implant an ICD in combination with pharmacologic therapy for a CPVT patient post-cardiac arrest, or no, you will not, or are you still not sure? And we'll give a minute for people to put their answers in. Kara, I'm not seeing your screen.
Okay, let me try again. Hold on.
Okay.
Can you see it now?
No, not yet.
Oh, really?
It does say you have started sharing, but it's empty.
That's weird because it says I'm sharing my screen. Okay, let's see.
All right, well, while Kara is still figuring this out, I hope everyone is still voting.
How about now? Can you see it now?
No.
I feel like Scott may be tampering here. He's very close to Kara's office. I've seen him in there at night. I think he knows her passwords.
It is Silicon Valley, so I did hack in and able to make some changes here.
You still don't see it?
No.
There we
there
go.
you
There it
go.
goes. Okay, there we go.
All right, it looks like we have 14 answers. And
I think that's the pre-debate poll.
oh, let's see. Oh, okay, 24 answers, and it looks like 67. So a third now think that they will not implant an ICD and will start with pharmacologic therapy first. All right, well, it was a great debate, guys. I think that this is an important topic and that obviously both sides had important points. And I'm gonna hand it over to Eric in case there are questions for Scott and Shu.
Thank you very much. Thanks, guys. Both great talks. Scott, there is one question about how do you program the defibrillator to minimize shocks? You mentioned it a few times that it's important to do it, but can you be more specific?
I'll say a couple things. First, I have a patient actually similar to Shu's who was a 4-year-old who had VF, was resuscitated. And this is a long time ago, sort of when Shu's early data came out, and mom was a nurse, sort of like Jen's case. And I tried to convince them to put an ICD in, and they didn't want to put an ICD in. So no ICD, just went home on beta blockers, and was very compliant. That morning in school one day, took her beta blockers between 1 and 2 per kilo per day of Nadolol, had a subsequent cardiac arrest without an ICD. Was resuscitated, but had some serious neurologic issues after. So I have not put an ICDs and been burned before. So that's one case, but an important one, I think. So counter Shu's. But I think it's really important to program really high VF zones. So 240 milliseconds or higher. I would not be programming low VT zones, maybe some VT monitor zones to pick up any arrhythmias, but programming really high VF zones is the key, and no VT zones that could provide any shocks below that. There is the caveat, is that going to sort of, are you going to undersense some fine VF at lower, at really fast rates? And could you undersense some VF there? We have not seen that, but I think the data is clear, as Shu and others presented, that we do have to be really careful about causing harm with shocks. And so I think that's sort of the key.
All right, well, thank you to all the speakers and everyone from around the world who joined us for this joint PACES and SADS virtual conference, the diagnosis and management of CPVT. Thank you again to SADS for working with us to put this together. They helped organize the program and run much of what you saw today, and for everything they do for our patients and their families in dealing with these inherited arrhythmia syndromes. We look forward to continuing to work together for a long time with virtual conferences and hopefully in-person conferences at some point. If you joined the session late or you missed any part, you can go back and review the session on the WOVA app or the website, and SADS will also be posting all the talks on YouTube in the coming weeks. I also want to take the opportunity to thank Medtronic and Boston Scientific, who both helped sponsor the event today. SADS will be sending out an email soon asking for feedback, and we'd appreciate any comments you have for us about what went well and what we could do better. Obviously, knowing where to look in the chat to try and find the questions would be important next time. Please stay safe, have a wonderful weekend, and thank you very much.